a few minutes to join, and then we'll start. See a lot of people come up on the screen, but we'll just give a couple more minutes. So for those who are just joining, we'll just give people a couple of minutes to join, and then we'll make a start. Okay, so we haven't got anyone else joining at the moment. So it's just gone 6 and other people can join. So a few just quick housekeeping things before I introduce Rob. Just if you're not speaking, if you're just on mute, that would be really helpful. And just to say that we're recording this, so it will be uploaded afterwards so that people who can't make it tonight can listen to it. So please pass it on to colleagues who might have wanted to join but haven't been able to. So the next thing I want to do is to introduce Rob Tobin and say welcome and thank you very much for agreeing to do this session on consent. So some of you will know Rob and will have worked with him across the trust. He's a partner at Kennedy's and he advises the trust on clinical negligence and health law matters. He's also a legal advisor to the Intensive Care Society on their legal ethics and advisory group. So we're really grateful, Rob, to you giving up your time tonight to do a short talk and then to take some questions around the issue of consent. So welcome.
Thanks, Sue. It's always worrying, I think, when a doctor knows a lawyer in a trust, because it's usually because they've been involved in something, and it's exactly the same when a patient like me knows a doctor for other reasons. But I'm very pleased to join you today. I will just share my screen so you can see the slides, and hopefully you can see them now. As Sue said, I've been asked to talk to you and with you about consent. It's really, I mean, the whole thing is a refresher because I'm sure you all know a lot of what I'm going to say, but I suppose what's changed in the last few months in consent is the GMC updated their consent guidance in November 2020. And so I'll talk about the new guidance and the impact of Montgomery generally. And there'll be an opportunity at the end to ask questions. I know we've had a couple of questions already, and Sue and I will talk through those at the end. But please do ask questions either in the chat box and then at the end, or if you really want to ask a burning question during it, I'm happy to take that. The basics, you know what consent is, hopefully, the voluntary and continuing permission of the patient to receive a particular treatment. And this is the second part, is what Montgomery really discusses, and GMC, and it's based on the adequate knowledge of the purpose, nature, and likely effects and risks of the treatment, including the likelihood of success and alternatives to it, and of course the likelihood of all of those risks if you don't have any treatment. Very quickly, I mean, Montgomery was a 2015 case, an obstetrics case concerning Nadine Montgomery, who was a diabetic. She had gestational diabetes and was deemed to be at high risk pregnancy. The doctors felt that she had a 9 to 10% risk of shoulder dystocia during delivery, but she wasn't informed of that risk. And the treating obstetrician felt that it was possible, or the possibility of that risk materializing was small. The shoulder dystocia did occur and the baby suffered severe brain damage. And Mrs. Montgomery was vocal over her concerns. So the whole case centered on whether or not she should have been told about the risk of shoulder dystocia and given the option of a cesarean section, an elective cesarean. And the court, and ultimately the Supreme Court, agreed that she should have been. What the case was originally argued on, the law is a Scottish case originally, was on the Bolen principles. And I'm sure you all know Bolen principles are centered around the responsible body of, in this case, obstetricians, and whether there was a responsible body who, acting reasonably, would have consented Mrs. Montgomery in the same way. And the court, the Supreme Court, looking at the GMC guidance and the law generally as it was then, felt that that wasn't the test that should have been applied. And really, the doctors should have concentrated on Mrs. Montgomery as an individual rather than concentrating on the doctors as a reasonable body in a responsible body of doctors. So I suppose what the outcome of that case was that the doctor is under a duty to take reasonable care to ensure that the patient is aware of any material risks involved in recommending the treatment and of any reasonable alternatives or variants to that treatment. And this really is a shift in focus, although arguably the law hasn't changed. It's just everyone was well, not everyone, but some people weren't following the law before Montgomery, and they should have been, because the focus should be on the reasonable patient, not the reasonable doctor. And this case was one of a number of cases that shifted the focus to the individual. And another case which many of your colleagues or you will be familiar with, CUH, is the Tracy case involving DNA CPR. There have been others with the Cheshire West case, which was involving the Dole's deprivation of liberty safeguards. All of these cases move away from the collective approach and the paternalistic approach to medicine to the individualistic, patient-centered approach. Now, I suppose the thing that exercises all clinicians' minds and lawyers, of course, is materiality and what it is. And this is where it's very difficult to define, because every patient is different. And so every patient's view of what is material is different. You have to focus on the individual. You have to ask the patient what they would want. And I suppose you have to know the patient as well as you can before deciding what they ought to be told about. And I'll come on to the GMC guidance in a minute, because that really effectively gives you, or ensures that you should basically tell them everything. And I'll come on to the whether or not that's actually something that can be done. What you shouldn't really do is just give numbers. The law, and there's been a few cases since Montgomery, which has really tried to shift away from you've got a 1% risk of this, you've got a 10% risk of that, because first of all, it's quite meaningless for a patient. If that 10% risk actually materializes for the patient, then they've got 100% risk of it happening in hindsight. And from a legal perspective, it's very difficult to defend those cases, because the patients will always say, well, if I'd known about this risk materializing, I wouldn't have consented to this procedure. So it's much better to channel your discussion around the likelihood of something happening to the patient against the risks of it, or the risks of other things happening if they don't have the treatment, and the benefits that go alongside all of that. There are a couple of, or three exceptions, and I'm sure you know these anyway, and these are exceptions to the principles of Montgomery about what you should discuss. One is the therapeutic exception. If disclosing certain information to the patient would actually be detrimental to their health, and really here we're talking about psychological or psychiatric harm rather than distress, so harm caused to that patient by telling them all of those things that could well happen to them, then you need not describe certain things. The reality is, I don't think that therapeutic exception is going to come about very much at all. Yes, a patient will be distressed with hearing that there's a 10% risk of death, for example, but with a procedure. But I think it's quite a high bar to say that they shouldn't be nonetheless told about that. Necessity, so if a patient doesn't have mental capacity to make a decision, then of course you're going to have to treat them in their best interests. And if a patient specifically says to you, I don't want to be informed of these risks, on that third point, again, I think it's quite rare, and you should really try to encourage them to have a conversation with you. And if the patient is absolutely adamant they don't want to know, then you should certainly write down in the notes that the patient has expressed that wish, and nonetheless you feel that it's in their best interests, even if they've got capacity, it's in their best interest to have that treatment. So that's Montgomery, just as a background. And then GMC guidance came in November last year. The 2008 guidance, so the guidance that was replaced, had this sentence in relation to material risk. And it said, you must, and I've emphasized these words myself, you must give patients the information they want or need to know about the potential risks, so the potential benefits, risks and burdens, and the likelihood of success for each option. The new guidance shifts away from that, or I mean, it goes further in a way, because it says you should usually include the following information when discussing benefits and harms. Any risk of serious harm, however unlikely it is to occur. Now, looking at that on the face, that seems incredibly broad. You know, any risk of serious harm, however unlikely it is to occur. So if we're talking about materiality, you could interpret that to say, well, even if there's a 1 in a million chance of something happening, you need to tell them about it. And there was a bit of controversy after the guidance was released, and the GMC tweeted this quote in the middle here. It said, our updated guidance is actually less prescriptive on this point. We've changed the wording from must to should usually, trusting doctors to use their professional judgment to apply the guidance in proportion to the specific circumstances of the decision. So what they've said there is use your common sense, I suppose. Know your patient, have a good discussion with the patient to understand what they would want to know and what they would regard as material and important in making their decision, and then make a decision yourself about what they ought to be told about. So it hasn't changed significantly on the level of risk, but it is notably beyond Montgomery. I think the important thing to remember with this guidance, and it's the same with all guidance from a legal perspective, is it is just that. It's not a policy, it's not a protocol, it's guidance. Yes, you should try and follow it because that's the best practice and that's what the GMC has recommended, but it's not the black and white law. It's something to follow. So these are the types of things that you should usually include when you're giving information to a patient so that they can make a decision. So the diagnosis and prognosis, if you're not sure about the diagnosis and prognosis, any uncertainties around that, including options for further investigations, options for treating or managing the condition, including not treating and taking no action, the nature of the option or the options, what would be involved in the desired outcome, and the potential benefits, risks of harm, uncertainties about the likelihood of success for each option, including the option of taking no action. And this is again the shift away from the paternalism. So you shouldn't rely on assumptions about information a patient might want or need, or factors a patient might consider significant, or what you think would be important to a patient. You have to put the patient at the center. And I mean, an example, I suppose, would be if a patient has injured their hand and you've no idea what they do for a living, you should find out if they happen to be a craftsman, if they happen to be a carpenter who uses their hand a lot, or the example is always given as a concert violinist or a concert pianist. And I don't know how many concert pianists you encounter in your day-to-day practice, but it is an example given. And the important thing is, it's asking the patient, having a conversation with them to find out not only about their health, but their wishes and fears. What activities are important to them? What would they describe as important to the quality of their life, personally and professionally? And then you can make that decision. So when we talk about Bolam and the reasonable body and the reasonable patient, it's an objective and a subjective test we have to look at here. So objectively, what would you as a doctor need to get across? What information do you think is important to get across? But subjectively, what does the patient in front of you regard as important and material in their decision making, so that the 30-year-old carpenter just starting out in their career may regard a 1 in 10,000 risk as material to them, because if that risk materializes, their career might be ended. So it's just, these are the things you have to bear in mind when coming to when starting your conversation. The risks and benefits that you have to discuss are just that. You have to give the patient clear, accurate, and up-to-date information. It's based on the best available evidence about the potential risks and harms of each option. You are expected, obviously, to have your knowledge up to date. You're not expected to know of every single possible research paper that's out there, or research paper in the offing, or treatment that may or may not materialize in the future. And this is where the Bolam reasonableness test does remain. So from your perspective, what would a responsible body of doctors, neonatologists, urologists, whatever specialism, be reasonably expected to know about, to be able to discuss with the patient in that discussion? That's where Bolam stays. But then, as I say, you go on to the subjective reasonable patient in front of you test as well. I mentioned that comparison between the 2008 GMC guidance and the 2020 guidance in relation to what serious risks of serious harm should be discussed. And these are the things that you should usually discuss. And I've emphasized should usually here, because it's not prescriptive. You don't have to mention all of these things, but the guidance says you should usually, and that includes the recognized risks of harm you believe anyone in P's position would want to know, effect of P's individual clinical circumstances on the probability of a benefit of harm. And I suppose that might be P's age and prognosis. If, say, they have an underlying condition which is likely to shorten their life considerably, and you are recommending a hip replacement, and you happen to know that the lifetime of that prosthesis is, say, 15, 20 years, but the patient is very unlikely to live that long, then the risk of it going wrong in 15 years' time may not be as relevant to that patient as the next patient. Doesn't mean you shouldn't mention it, but it may not be something to put in the forefront of the patient's mind or yours. Risks of harm and potential benefits, P would consider significant. Any risk of serious harm, however, unlikely is to occur. And there's that number 4 catch-all, which the GMC tweeted about and said, well, use your judgment. Expected harms, common side effects, and consider using visual or other explanatory aids to support P's understanding. And this is where the it's so important to write good notes and explain how you've come to your conversation, because there may be patients who either through lack of understanding, perhaps they don't speak English very well, or perhaps they, for other reasons, they can't communicate very well, but they may benefit from alternative communication aids. You should use all possible means to get the message across so that they do understand what it is you're trying to convey. I'll mention quickly delegation here, because I know some people, particularly, well, a lot of consultants, I'm sure, will want to delegate some of the consent discussions to juniors. That's fine. But the important thing is that the person you're delegating to must be suitably trained and competent. They must understand and have sufficient knowledge of the intervention, the treatment, whatever it is that's being proposed and discussed, and its associated benefits and harms, and all the alternative treatments. They have to have the skills to have a dialogue with the patient. They have to feel competent to carry out the task and understand and agree that they will refer to you or a colleague for advice. And really importantly, you're still responsible for them. So if you do delegate the process of consent, the buck stops with you nonetheless. And it's very important when you do see the patient again, perhaps just before surgery or in your follow-up consultation before surgery, once consent's been discussed, that you should reiterate that discussion as best you can and ensure that the patient understands and has fully informed consent. And I touched on recording before. It goes without saying, and a lawyer is always going to say you should write impeccable notes. We see, sadly, many claims involving consent or lack of consent, and it tends to become almost a catch-all pleading at the end of a lot of particulars of claim or letters of claim. So there'll be an allegation, say that the surgery went wrong, surgeon perforated something during the procedure, or as in the case of Montgomery, patient wouldn't have consented to the procedure at all had they been aware of all the significant risks or material risks. And then we look at the notes and they're very sparse. Either that there's a very short consent form which just says risks discussed, including, list 2 or 3 risks, and there'll be a signature at the bottom, or 2 signatures, the surgeon and the patient. Whilst we would expect an essay, we are realistic, and we know that you don't have very much time to record your consent discussions, but more is obviously preferable. And when you are recording your discussions, I wouldn't just record the risks and benefits that you discussed. I would also, as best you can, paint a picture of the context around the discussion, so that you can say, for example, I discussed the fact that the patient is a carpenter, uses their hands a lot, and is very concerned about the loss of use of one of their fingers if this went wrong, which is why I explained this particular very rare risk, which the patient regards as material and significant to them. And importantly, from a mental capacity perspective, that they have mental capacity and they understood all of the risks and described them back to me. That is a very whistle-stop tour, because I wanted to have time for questions at the end, which is now there's time for questions. So I'll stop sharing my screen. And Sue, do you want to?
Yeah, no, thank you. Thanks, Rob, for that. It was really sort of helpful summary of the changes with the GMC guidance. I've got a couple of questions to ask, which a couple of the consultants have kindly shared with me in advance. But for others, if you're either happy to put it in the chat or put your camera on and wave at me, because I'm scooting across a couple of pages, so I might miss you. But if I either would be fine. But the chat is probably more guaranteed for me to see it. So Rob, just while other people think about what they might want to say, there's a couple of questions that have come in that I touched upon in your presentation, but I think are worthy of a little bit more discussion. So one's from Bill Turner. The GMC guidance from November 2020 has a really notable paragraph at paragraph 30, which states, you must check whether patients have understood the information they have been given, and if they would like more information before making a decision. The guidance doesn't really clarify how we check that people have understood the often complex information that's been discussed with them. I know you've touched on that a bit, but the question particularly here is, we often check whether healthcare professionals have understood information they receive by some form of test. Is that what would be expected of a reasonable medical practitioner in this situation, or do we just simply ask people if they've understood it?
It's a really good question. I mean, the answer is no, you shouldn't just assume they've you shouldn't just ask them if they've understood it. I think there has to be, well, let's not call it a test, because I don't think you can ask them to sit an exam, particularly given the complex medicine you're probably discussing. But I do think some kind of dialogue needs to be had with the patient. An example, I mean, you know, every doctor will have their own way of doing this. One way I would suggest, and I know it's been used in the past, is effectively asking, you know, say to the patient, well, will you tell me in your own words what we've just discussed, and so you can get a true understanding of their understanding. You might say, like, for example, if you know that patient, let's say they're an elderly patient and they're cared for by one of their children, you might say to them, I assume you're going to go home now and discuss this with your daughter or son. Tell me, what are you going to talk to them about? How are you going to feed back what we've just discussed? And ask them to effectively teach you, tell you what the procedure is. Or you might just say to them quite simply, can you just talk to me, tell me what I've just told you, and then you can get a sense about whether they've understood it. And it may well be they haven't, in which case you probably have to have a further conversation or go into a bit more detail, or perhaps use layman's terms. I mean, what you don't want them to do is just repeat verbatim what you've just discussed, you've just said, because, I mean, apart from anything else, the Mental Capacity Act, one of the limbs of the test to see whether someone has capacity is whether they can use and weigh the information pertinent to the decision. And if it's regurgitated, you know, it's going in one ear and out the other, then they probably don't, I'm not saying they don't have capacity, but they may not have capacity, or at least they may not have understood what you've just described, in which case you need to try again. I think it's called the teach back method, where you basically get the patient to teach you what you've just recommended. Does that help? Does that help, Bill?
Does that help? Bill, does that answer your?
It's very helpful. Yeah, I think it's inherently difficult, isn't it? There'll be lots of complex treatments that places like Addenbrooke's offer, not just surgery, where there are multiple different aspects, and there may be a number of different treatment options to weigh up. And I suppose you've touched also on the one hand, there is there's, if you like, the legal viewpoint, and then there's the professional and regulatory viewpoint, and the GMC is not the legal one, so maybe you must check, which is absolutely prescriptive, is less crucial from the legal point of view. But checking that people have understood a broad range of complex information, it feels to me that the people who wrote the guidance didn't really have much connection with complex interventions.
I imagine that's right. And I suppose what you don't need to do is you don't need to ask the patient to explain how the procedure is going to be performed. Like, for example, if it's complex, well, any surgery is complex, but cardiac surgery or something, the patient isn't going to be expected to explain and describe all the incisions and all the arteries and things. In the same way that a person consents to getting in a car, you don't need the person to understand how the car drives, how the motor works, or how an airplane works. But you do need the patient or the passenger in this analogy to understand there is a risk that by my getting in the car and it going very fast, and this person who's only passed their test last week, say, there is a risk to me that I might get injured, and I understand that risk and I'm consenting to that.
Yeah.
But I agree with you. I think it's deliberately vague, I'm afraid, but it's not helpful.
Thanks, Rob.
Thanks, Rob. So there's a question in the chat. What's the best way to consent patients for treatments where 2 different treatments are available from 2 different specialties? How would we approach that?
Well, ideally, you'd have both. You wouldn't do it alone. You would have the other person or the other specialist with you to describe all options. I mean, certainly the patient should be given or told about all of the options available. The key word there is available, but that might not be practical, and you might have to do it in a 2-stage process where one person says one thing. And I mean, I think this is where MDTs come in. I think it would. Well, I know it would be very helpful to have the MDTs so that the 2 specialties can discuss the options together. And it may be that both options are equally valid ones, and it's really up to the patient to decide, based on all the risks and benefits of each, what they would want to do. I don't think it will be helpful for one of those 2 specialities to unduly influence and really recommend their procedure over another before they've had a proper discussion in the MDT and agreed amongst themselves, specialists, what would be best for that patient. I mean, it's still ultimately the patient's decision, but what you don't want is a patient being confused because they're having 2 specialists recommend something and they really can't make a decision. I suppose that's another way of getting around that, is to have a third person in the room to mediate or help the patient advocate and get around that mire of information.
Thanks, Rob. A couple of people have, not in the message box, but have just highlighted in emails, is one of the perennial challenges for us in clinical care is the balance between providing the most appropriate consent that we can for our patients, but the time and the resource pressures that we're under in, for example, an outpatients clinic or a pre-theatre list. And I know this is a perennial question that I've certainly asked you before, which is a difficult one to answer. So the question is the balance and what your thoughts are on a lawyer as to how we do that in a very pragmatic way in terms of how we practice, and whether there's any technology that might help us with that, because at the moment, that is something that is then being collated and entered into the notes by the clinical teams, and the ever-increasing pressures of recovery will only add, I think, to this for staff day-to-day working in different areas all across the hospital.
Yeah, it is a perennial issue, and I mean, you asked me for the practical answer, I suppose. A practical answer is to have a scribe, to have someone with you who can ideally take a verbatim note of all the discussion. I think what's very useful in law, in the legal cases, is the cases where the clinical notes may be okay, but there's a very good detailed letter to the GP following up that consultation, dictated usually, and it will go into some detail about the discussion itself, and that obviously is shared with the patient, so they have a record of it and they can look back at it. But 3 years down the line, when there's a claim, we have quite good detailed information and evidence of that discussion. But I do recognise, and the courts do recognise as well, that you don't have very much time, and with the best will in the world, you haven't got time to write an essay every time you consent a patient. Having said that, I think the more complex the treatment or the higher the risk to the patient of that treatment, the more time and better notes need to be taken. In terms of technology, it's almost like you've set me up there, Sue, because I am actually working on.
I promise I haven't.
I am actually working on an app at my firm about consent, and because I personally think that consent, to capture all of the discussion, the best way to do it is to record it, as in audio record it. Obviously, you need the patient's consent to do that, and I know many patients covertly, or not even covertly, sometimes overtly, bring their smartphones along and record your discussions anyway. I think it'll be much better if it was done formally, and that recording sits on the patient's record, and it also gets shared with the patient so they can listen back to it. It's not instead of the consent form, but it's gold dust in terms of evidence. And I think a clinician is far more likely to give have a good consent discussion and really explain everything if they know they're being recorded. And the analogy is the black boxes in airplanes, which is incredibly useful evidence. It's also very good for auditing each other, colleagues, and seeing if anything could be done differently or better, and finding good examples of consent and sharing that as an education piece.
Thanks, Rob. That's really helpful. I've just seen George has come on the call, and he had a question which I'll read out, and then George, please add to it if I haven't captured it correctly. So within oncology, there is often a lag between licensed approval of a new cancer drug and NHS commissioning via NICE or NHS England for the routine use of the drug. On some occasions, a company may have a drug approved by NICE for one line of therapy, for example, relapse disease, but will not submit to NICE for approval for alternative lines, despite having an approved label for those lines. The assumption is that this is based on cost, but under the current NICE operating model, they can only look at a drug and an indication if a company submits an application for use on this application, for use in this indication. And there are many examples, particularly in some specialties, like blood cancer, for example. So the question is, if we're consenting a patient in an NHS clinic for blood cancer treatment with an NHS approved drug, does the Montgomery ruling, or indeed the new DMC guidance, mean that we have to mention that there are alternative ways of treating the patient's blood cancer that are available in the UK, but not available in an NHS clinic?
Okay. Yes, I think again, there's that word again, available. I think if something is available in the UK, and it's something that you feel that patient ought to know about, or would want to know about, then I think you should tell them about it. But you should also tell them, I mean, because the question was also predicated on this approved issue, NICE approved, or if it's licensed or unlicensed. I know that comes up as well. It's not to say that it wouldn't be recommended if it was something that was deemed appropriate, but I think the patient should be aware in that conversation that there may be, whilst it may be available in the UK, it may not be literally available, because they may have to pay for it, and they may not be able to afford it. and or there may be a long waiting list for them, and you can't guarantee that they get it. So I think with all of those caveats, I think it is appropriate to let the patient know that there is another option out there. I think we use the word, or part of the question talked about the UK. I don't think it's necessarily constricted to the UK. There have been a few cases recently which have talked about treatment outside of the UK, particularly in the EU. I know that's slightly changed now with Brexit, but there was a case a few years ago, the Aisha King case, where the young child was, or the parents wanted that child to have proton beam therapy, and at the time proton beam therapy wasn't available in the UK, and there was I don't know if you remember, there was a whole child safeguarding issue about removing the child. And I think there have been other cases, Tafida Akiba's one, where the issue was whether or not the parents ought to have, it wasn't really consent, they weren't consent cases, but I think they would be stretched consent cases to say, well, should the parents in those cases, or a patient, be aware that there is another option available? And again, it's about whether it's available to that patient. So if it exists in America, say, as far as you're concerned and your commissioners are concerned, it's not available. Patient may decide to pay for it and go out to America. That's up to them. And if they've asked you the question, if they say, I'll do anything, I'll sell my house, I'll do anything, then you can say, well, I'm aware of some experimental drug or some experimental therapy that's happening in the States. I can't recommend it because I don't know anything about it, but you're at liberty to look at it yourself. Then I think it is appropriate to tell them about it. I don't think you'd be admonished if you didn't, because again, it's that available thing and it's within the scope of your remit. So the NHS, if it's available or exists in the UK, then yes, for that particular patient, if it's something that they would regard as material, then yes, you should tell them. But I'm just adding that can of worms about the outside the UK and those circumstances where, for the patient who really wants to know and is prepared to pay for it, you might want to tell them about stuff that's available elsewhere as well.
George, anything you want to add to that?
So Rob, you take an extreme example of the patient almost facing an end-of-life care decision. I think what I'm more referring to is an everyday problem you have in cancer care, that there is this divergence of practice between what is approved as a licensed drug and what has been commissioned for our use. So everyday patient, 70-year-old, first-line therapy with a condition they're going to have for years, and NHS has approved drug ABC, and yet there's D&E that could be available if this patient turned around and said, actually, I've got healthcare insurance, or actually, I want to pay for it. Are we obliged in our clinics to talk about D&E? And I don't like paternalism at all, but inevitably people make those paternalistic decisions when they have a patient in front of them. I think it's more the routine guide than this guy is dying and I've heard there's a treatment in America, we could ship him over for proton beam, which is a much more rare occurrence, I would have thought.
I suppose the question is whether options D&E are something that are it's a genuine treatment that ordinarily you would offer them as an option were they available through the NHS. And if so, then I do think for those patients who can afford it, they ought to be told about it.
But we don't know whether they can afford it, and we don't know whether. I mean, it is a real practical issue on the ground. So we make the decision not to talk about these things in routine practice. But for a long time, for instance, in chronic leukemia care, one of the drugs, ibrutinib, which is a tablet, minimal side effect profile, approved in the relapse setting, but the company would not take it to NICE because of the quality metrics that you have to assess the cost economics on. The drug wouldn't be approved first line because the patients live for too long. So there's a complete disconnect. So for a number of years, if you're in the private sector, you would be treated with these tablets. If you're in the NHS, you get intravenous chemotherapy. And how that is handled, thankfully, we've now got one of the tablets, a new one from AstraZeneca that's been approved. But for a number of years, it really was a difficult area in our practice.
I don't think there's a straight answer to this, I'm afraid. I mean, I think there was a case a few years ago involving Herceptin, if you remember that, and it was again about funding and the fact that Herceptin wasn't, I think it was for breast cancer, am I right? And that wasn't available, it wasn't commissioned through the NHS, and it was, as I understand it, a treatment that some clinicians recommended and would have recommended wholeheartedly if it was available. I suppose my answer is I think yes, you ought to at least mention to a patient that, and the conversation should go like this: I am recommending this drug for you. This is the drug that's available in the NHS at this clinic. You ought to know that there are other drugs available. Sorry, there are other drugs in existence. I can't recommend them to you because they're not commissioned. They're not. I can't. The NHS won't pay for them. But in the same way that you are obliged to explain alternative treatments that are, again, that word available, I think the patient ought to know about it, but they ought to know in the context of, well, there is this drug in existence, but it's not available on the NHS. You are welcomed, if you want to seek private consultation and pay for it, or if you've got insurance, ask your insurers to pay for it. But if you want treatment with me, this is what's available.
Thank you, Rob. Difficult area.
Yeah.
Thanks, Rob. Are there any other questions? I can't see anything else in the chat or any hands go up.
Sue.
Yeah, Bill, go ahead. Yeah.
Just if there are no other questions, Rob, it's about unforeseeable risks. So risks not previously encountered or documented or published. And I'm sure people listening who have been involved with, again, a range of complex treatments for long enough will have encountered numerous the problems which are commonly described, but also probably things which they had never heard of before, never seen described or published. And I wondered what your view is on saying to people, as well as all of the things that we've discussed, all of the recognized previously documented risks. Most of us who've been doing this for long enough have seen things for the first time that we never had imagined might occur, and that possibility exists with all kinds of complex treatments. Do you think that's a reasonable approach, or is that just likely to be unsettling and unhelpful?
I think the latter. I think it's going too far. Because it will be unsettling, I would have thought, because you can't be expected to consent someone for something that you have absolutely no idea is going to happen. I mean, the difficulty I have sort of linguistically is that phrase, recognized complication, because as a patient or a potential patient, you know, if a doctor says to a patient, well, this is a recognized complication, a reasonable patient could turn around and say, well, hang on a minute, if you know it's a recognized complication, make sure it doesn't happen. You know, look out for it. Of course, one of the answers to that is, well, every human's body is different, and you can't know exactly what's you're going to find when you open them up. And I recognize that. But but taking it to the extreme is effectively what you're suggesting, and I don't think that would be. It certainly wouldn't fall under the GMC guidance as required, and I think it might be unsettling and unnecessary, and it might go under the therapeutic exception of not necessary. I suppose the caveat is for those clinical trials where you simply, I mean, the nature of a clinical trial is you won't know, and that's where the ethics committees come in to decide whether or not certain treatment should be recommended to patients. And I mean, the current example, as we all know, is the vaccine. And I can tell you, having recently had the vaccine, the consent was diabolical. And I don't criticize anyone for it, because they had to consent, or they had to give vaccines to thousands of people a day. But, you know, first of all, no one quite knows all of the risks and benefits. They know most of them from all the data. And I was certainly very comfortable having it because of all of that. But no one describes, and no one can describe all the potential risks that no one knows about, because that's the nature of urgent vaccinations, I suppose.
Thanks.
Rob, just in the last few minutes before we close, I just wonder, there's quite a lot of paediatricians on the call that I can see, and I just wonder if there's anything specific you would want to draw out from the GMC guidance that might be particularly pertinent to consenting for children, recognising that there'll be many other specialties that will consent for children who are not sitting in Division E or in paediatrics specifically.
Yeah, I mean, nothing's really changed in a sense, because it's the same principles apply for children. And I mean, by children, obviously, it depends on their age and their competence, their Gillick competence. But assuming we're talking about a Gillick competent child, then the same principles apply. The language used might have to be altered to ensure that the patient understands, but not necessarily. But it may have to be. Parents, people with parental responsibility, if the child or the person, the Gillick competent child is happy for the parent to be in that conversation, then they ought to be. It's obviously different for children in your line of work, Sue, who clearly don't have Gillick competence, and then it really is about the parents. And we've had cases, and I've had cases with CUH recently, where two parents disagree, two parents with parental responsibility don't agree, and that's a hugely difficult problem when it is a life-sustaining treatment you're discussing. But I think from a consent perspective, the principles remain that all material risks will need to be discussed. I think the therapeutic and the harm issue might be more relevant for a child. You know, and this is going to be, it will change for every child, but does a 13-year-old child need to know the risk of death if it's a very, very tiny risk for, I don't know, an appendectomy or something? But that's going to have to be a clinical decision for the doctor when consenting.
Thank you very much, Rob. So just on behalf of everybody, I'd just like to say a huge thank you to you for giving up your evening to talk to us. It's been really insightful and useful, and I think very relevant for all of us in day-to-day practice. So thank you very much for that.
My pleasure.